This is PediaCast. CME.
Welcome to PediaCast, CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We are in Columbus, Ohio. It's episode 47 for July 24th, 2019. We're calling this one Splinting the Lower Extremity. I want to welcome everyone to the program. So we are back with part 2 of our Super Summer Special experiment on PediaCast CME as we consider splinting as a primary care office procedure. We covered splints of the upper extremity last month, including slings and clavicle straps, posterior long arm splints, sugar tongue splints, short arm splints, including volar, thumb spica, ulnar gutter, and radial gutter varieties. We also talked about finger splints. This week we are heading south and covering the lower extremity, including long leg posterior splints, short leg posterior and stirrup splints, knee immobilizers and Shauns Wraps, Aircasts, and Reese shoes, along with the proper sizing and teaching for crutches and crutch walking. And like last month, we have the audio podcast, which you are listening to right now, along with videos of all of these splints being applied, which you can find in the show notes, episode 47, over at PediaCastCME.org. We'll have the links to all 5 of those videos for this particular episode. So you'll want to listen to the podcast and watch the videos before you take the post-test and claim free Category 1 continuing medical education credit. And more on exactly how you do that in a moment. We will be offering 2 hours of CME activity for this particular project. So we have to, again, listen to this podcast, watch the videos, take the post-test. That should take you about 2 hours to complete. Now, you'll notice I did say this was an experiment. We have not covered office procedures before on this podcast, and we have not included videos along with the audio podcast, except for last month, of course, which is when we began this experiment. That was part 1 in June. Now here in July, part 2. And, it's a first for us, and honestly, it may be the last, depending on how well this is received. Or maybe it'll become a summer tradition. Who knows? Time will tell. I will say that last month's activity with splints of the upper extremity was very well received, and so hopefully this one will be as well. My guests are the same. Dr. Marc Leader, he is a urgent care physician, actually emergency medicine physician, director of urgent care services for Nationwide Children's Hospital, and James Robinson is a suture and orthopedic technician with many years of experience here at our institution. They'll join me again in just a moment. Don't forget, you can find PediaCast in all sorts of places. There may be an easier way for you to listen to the program. We are in Apple Podcasts, Google Podcasts, Google Play, iHeartRadio, Spotify, most mobile podcast apps for iOS and Android, also on SoundCloud. So lots of ways that you can access the audio podcast, and also at our landing site, PediaCastCME.org. And again, you'll find the show notes for this episode 47 there. And that's where we'll put the links to all of the videos so you can watch them as part of this activity. We also love when you connect with us on social media. We are on Facebook, Twitter, and LinkedIn. I really try on pretty much a daily basis to share news stories with you that I think would be interesting to the pediatric and parenting crowd, usually pertain to pediatric child health, maybe parenting topics. So please do connect with us on Facebook, Twitter, or LinkedIn if you have not already done so. And then also on Instagram, where we give you a more personal look into the studio, also into what's going on in my family's life, just so that we can stay connected that way. So simply search for PediaCast, again, Facebook, Twitter, LinkedIn, and Instagram. All right, I mentioned that I would let you know how you claim free Category 1 CME. It's really easy. Listen to the podcast, watch those videos, make sure you read all of the CME information that's available in the show notes for this episode, again, number 47 over at PediaCastCME.org. And then if you haven't already done so, just register for your free PediaCast CME account, log into your account, and once you log in, at the bottom of the show notes page, the post-test will appear. So then take that post-test, and if you successfully complete that, we will send you a certificate by email so you can claim, again, up to 2 hours of continuing medical education credit, absolutely free, for listening to this program and watching the videos and then taking that post-test. While you are at PediaCastCME.org, if there is a topic that you would like us to cover as we think about future episodes of PediaCast CME, it's really easy to get in touch. Just search for the contact link. It's up at the top of the page. One of the tabs says Contact Dr. Mike. If you click on that and send the form in, I read each and every one of those that come through, and we'll try to get your topic in the lineup for a future episode of PediaCast CME. I also want to remind you the information presented in every episode of our program is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Our discussion may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment option, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Marc and James set up in the studio, and then we'll be back to talk about splinting the lower extremity. That's coming up right after this. Dr. Marc Leader is an emergency medicine physician at Nationwide Children's Hospital and a professor of pediatrics at The Ohio State University College of Medicine. He serves as medical director of our hospital's network of pediatric urgent care centers, which includes 7 locations across Central Ohio. James Robinson is an emergency services suture and orthopedic technician at Nationwide Children's. This means he works in our emergency department and urgent care centers, and he brings years of experience placing splints of all sizes and shapes on kids of all ages and sizes, from infants through young adulthood. That's what they're here to talk about today, splinting injuries of the lower extremity. So let's give a warm PediaCast welcome to Dr. Marc Leader and James Robinson. Thanks.
Welcome.
Thank you so much for being here today.
Thanks, Mike.
You're welcome.
Really appreciate it. So last month, we covered splints of the upper extremity on PediaCast CME number 46. This episode 47, we are talking about splints of the lower extremity. And I want to remind everyone that in addition to the audio podcasts, we have 5 videos that go along with each of these. So 5 for episode 46, 5 of them for episode 47. You want to not only listen to this podcast, but also watch all of the videos, which shows us applying all of the splints that we're going to talk about. And you can find links to all of those videos in the show notes over at PediaCastCME.org, again, for episode 46 and for 47. And since we have audio podcast and videos for you to watch, it's going to take about 2 hours of your time. So you can claim up to 2 hours of free Category 1 continuing medical education. And the information on how to do that is located on the website at PediaCastCME.org. So, Dr. Leader, let's start with you. Explain why primary care providers really ought to care about this. I mean, why is it worthwhile spending a couple of hours learning how to apply splints in the office setting to the lower extremity?
Well, thanks for asking, Mike. I mean, I think that injuries to the lower extremities are fairly common, especially, today is middle of July, and summertime is we refer to as our trauma season, and we see many, many injuries, many of which involve the feet, ankles, or lower leg. the common mechanisms being children are out now bicycling, rollerblading, roller skating in the playgrounds on monkey bars and falling, etc., and injuring themselves. And it would be nice if you have the ability to take care of these injuries that may present to a primary care office. Even if you can't provide definitive care, let's say for a displaced tibial fracture, you could certainly make your patient more comfortable by immobilizing them until they get to that place of definitive care.
Yeah. And there's lots of times when folks will come in and you're not really sure if there's a fracture there or not because it's not deformed, there's not swelling, and you send them off for an x-ray. I mean, it would be nice if there is a non-displaced, non-angulated, simple fracture and the family is able to come back to your office for you to put the splint on. I mean, that may be nicer for the family than seeing a new provider in urgent care that they're not familiar with.
Absolutely, and some of these splints that James is going to teach you how to place are fairly simple to put on and would very appropriately treat the injury, keep the patient immobilized, decrease pain, and ultimately be the same type of splint that they would get at an urgent care, emergency room, or orthopedic office setting. Yeah, and you can then also get a little extra revenue for placing these splints yourself. Yeah. So, James, tell us if I'm a provider who's interested in applying these splints in the office. I need to get together with the person who orders medical supplies for our practice. What sorts of things should we have on hand so that we're ready to apply any of the splints and devices that we're going to talk about today?
Okay. Dr. Patrick, actually what they would need first and foremost is the orthoglass splinting material itself. They would need a soft roll or web roll or cotton padding. Another apparatus is stocking net, which is also protective material for the skin. They would need ACE wrap to secure all this to the patient. They would need a good pair of scissors, actually, to cut your orthoglass material. Those are pretty much the things you would actually need to apply all these.
Yeah, and maybe some medical tape if you have the kind of ACE wraps that have the little clips rather than the Velcro like we have. It's especially with the little kids. It's nice to kind of put some tape over those so they don't pick them off, and then the whole thing comes unraveled. And then you really want various sizes and widths of all of these on hand so that you can apply it to any size child.
Absolutely. The pediatric population, they come in various sizes. So the orthoglass material, the ACE wrap, the web roll, the stocking net, all will come in various sizes from basically 1 inch all the way up to 6 inches. So,
yeah. And then we're also going to talk today about knee immobilizers, Aircasts, reshoes, and crutches. And so those are all going to be things also that you may want to have on hand. Yeah. With the crutches, it may become a space issue with having various sizes. I mean, those do take up a lot more room than some of the other things, but you certainly could, and we'll talk more about crutch sizing and walking in a few minutes, but you could always write a prescription for crutches. The family could take it to a medical supply store or one of the pharmacies that also has medical equipment, and then bring them back to the office so that you can make sure it is the right size and teach them how to use them.
Absolutely. Yes.
So let's start with the long leg posterior splint. Dr. Leader, what are some reasons that you would first, I guess, describe what this splint looks like, and then what are some of the indications for when we would use a long leg posterior splint?
So the long leg posterior splint would be applied so that the upper portion reaches to just below the cleft of the buttock, and the distal portion goes to the just below the toes, just until you get to the distal portion of the foot, the distal metatarsal region. We use them primarily for injuries of the tibia and fibula, injuries that where the knee and ankle need to be immobilized. A very common scenario is either a diagnosed toddler's fracture or a suspected occult toddler's fracture. So these are injuries to the tibia that usually have a spiral quality to it. This time of year, I think you should suspect these type of injuries when there is a history of being on a playground slide, for example, is a very common scenario where the toddler's leg may inadvertently be twisted. An example being if the child is sitting upon the lap of an adult as they go down the slide together, oftentimes the foot or ankle will be caught between the slide and the thigh of the adult, and there'll be a twisting mechanism leading to a toddler's fracture of the tibia.
There's lots of people cringing as they're hearing you describe that. Yes,
such vivid detail.
Yes.
But with that said, so the time to suspect that is when you have a patient who, let's say this toddler, 2-year-old, for example, who had been a weight-bearing, walking, running around the playground, and then after going down the slide is no longer weight-bearing. They typically will come in to the office or urgent care or emergency room and not be weight-bearing. But also they could be very upset, visibly, just from anxiety of being in an unfamiliar place. They may also be visibly uncomfortable because they have a fracture, and they could be crying or upset because of that. What the challenge to the practitioner is evaluating the patient and trying to decide where their pain is localized to. This is very challenging as you palpate down the femur and to the knee and tib fib region. They may cry the entire time. So it's very challenging to know what you should x-ray and where they may be hurting. So as a result, typically what myself and my colleagues will do is in the setting of a toddler who is no longer weight bearing, and you can't localize for certain where the injury is, we will x-ray the entire lower extremity, AP and lateral views from the pelvis to the toes, basically. The reason for that, to order those films initially, is you may order a tib fib film, let's say, to begin with, and it may come back as normal, and then you're still kind of challenged in your head saying, well, maybe did I miss something? Did I miss something in the foot? Did I miss something in the femur? And oftentimes these patients are bouncing back and forth between the x-ray suite and your office as you send them to and from trying to figure things out. So most of us feel that a better approach is to initially order x-rays of the entire lower extremity, AP and lateral views, and then reassess the patient. Usually what I do is I give them a dose of Motrin when they come in and see us. Before they go off to x-ray, I'll give the child a dose of Motrin. They'll go get their x-rays. Then I will see the x-ray report. Obviously, if there is a fracture noted, we will treat the fracture appropriately. If no fracture is noted and the films are read as normal, I re-examine the child. If the child is now weight-bearing because they received Motrin, I will not splint them. I will treat with Motrin rest and ice, etc. If, on the other hand, upon re-exam, they are no longer weight-bearing consistently, that patient will be put in a long leg posterior splint with a diagnosis presumptively of an occult toddler's fracture.
Yeah. And I love this idea of just getting x-rays of the entire lower extremity. And you could say, well, does that add cost? And is there increased radiation exposure? But really, for a lot of these kids, the cost of a whole lower extremity series is going to be less than each of those individual films. And usually you can use larger plates and actually get more bone in a single x-ray. So the radiology does a really good job of minimizing radiation exposure, especially if you're at a pediatric facility.
Yes, and practically it's just, I think, a better mechanism to do it.
Yeah. And then I also just want to mention ibuprofen. It could be Motrin, could be Advil, but we're not respecters of which brand of ibuprofen product that you happen to use. So just want to point that out. Ibuprofen. So the long leg posterior splint, as you mentioned, we generally want to immobilize the joint above and the joint below where we suspect there to be an injury. So these aren't really going to be good for femur fractures because they're not immobilizing the hip, correct?
Correct. However, with that said, if a femur fracture was to present to your office, you could certainly make them more comfortable for transport by putting them in a long leg posterior splint in your office. Any child with a femur fracture, almost without fail, is going to need emergent referral for orthopedic care and ultimately spica casting. But if they happen to show up to your office setting and you don't want them to be uncomfortable for the drive to the emergency room, particularly if they have to travel long distances, placing the long leg posterior splint in your office for a femur fracture until they get that definitive care is very appropriate.
Yeah. And if they were to come with a significant femur fracture, then you probably want to get EMS involved because they may need IV fluids, and there's a lot of bleeding that can happen from a femur fracture. If you're coming from an office setting to a definitive medical care facility, especially if it's going to be a long trip.
Sure, of course, and not to mention the need for IV morphine or pain control.
Yeah, absolutely. So with these posterior long leg splints, these are pretty heavy, and I just want to reiterate the fact if you have a young child, especially toddler age, who will not bear weight on an extremity after an injury, but the x-rays are all negative, you've given ibuprofen, they still won't bear weight on it. We apply a posterior long leg splint until they can be rechecked a few days later to see if the pain went away or it's still there, and then maybe they need a referral to an orthopedic doctor at that point. But these are heavy splints, and so what do you tell folks in terms, especially parents, how do you deal with this kid now with this heavy splint who's not bearing weight?
I'm going to let James answer some of that, but I will typically recommend that the parents do a series of things. One, carry the child. Two, they have the red wagons or green wagons that you've probably seen, and these are easily available. Many people have them already at their homes, or neighbors have them, and you can use those to transport the child around comfortably with that splint in place. James, you have anything to add about what you may say?
Actually, yeah, Dr. Leader, if they're old enough, say elementary age, we may recommend a walker. If they're, of course, coordinated enough, crutches. And if your office does not carry that, they can write for a script for that, and they can go pick that up and have them use it at home. Yeah.
And this is going to especially be the older kids, but Absolutely. The little toddlers, you're better off just carrying them. And
Absolutely. Yeah.
Not giving them a device that they may hurt themselves on further.
Right. Exactly.
And then, of course, pain control with ibuprofen is going to be important. In terms of applying a long leg posterior splint, James, we've kind of, and if folks watch the videos, you demonstrate applying a long leg posterior splint. And one of the things I really appreciate that you said in that video, and just reiterate the importance of this to us, is trimming those edges on the fiberglass splint. What's that all about?
That is actually a protective method to protect your patient from skin breakdown. Those fiberglass edges get extremely sharp and hard once they dry. If they are exposed beyond the cotton overlay and they touch the patient's skin, they can actually penetrate the skin. They come like little needles, so to speak.
Yeah. So when you cut the fiberglass material, the outer cotton material that's on the outside, and the fiberglass is on the inside. But some of those little shards may protrude past that padding,
right? And
so you want to actually trim the fiberglass shorter on both ends,
Absolutely.
Than the actual padding that covers it. And it's a necessary step that could be easy for someone to overlook.
Absolutely, yes.
So you definitely don't want to miss that.
All right.
And then the long leg posterior splint we talked goes from just behind the toes all the way up the back of the leg,
yes.
Across the ankle, the tib fib area, the knee, and up to the gluteal fold.
Absolutely.
And then as we talk about short leg splints, we have both posterior and stirrup splints. How do those differ from the long leg splint?
Basically the length. The short leg posterior splint basically will not travel all the way approximately up to the gluteal fold. It's going to stop basically 2/3 the way up the calf. And as the stirrup as well will stop right in that same distance as far as right 2/3 up the way to the calf.
And the stirrup splint, how does that go on? So it's U-shaped, correct?
Yes, absolutely. It goes from the medial and lateral sides of the ankle all the way up 2/3 to the calf.
Okay, and this is going to go under the heel.
Under the heel, exactly.
Just like a U. Yep. Sort of the equivalent of a sugar tongue splint, but instead of immobilizing the forearm, we're immobilizing the lower leg.
Absolutely.
Okay.
Yep.
And Dr. Leader, when would folks think about using a short leg posterior splint and a stirrup splint? And again, we do have videos of both of these being applied in the show notes.
We use the short leg posterior splint for injuries to the distal part of the tib fib region. Salter-Harris fractures around the tibia or fibula. These would be appropriately splinted in a short leg posterior splint or the stirrup. Primarily injuries around the ankle.
Yeah. Do you have a preference on which of those that you use, the stirrup splint versus the short leg posterior?
Either one is appropriate. Our orthopedists have gone more towards the stirrup splint than the short leg posterior splint. Recently, they made a change in terms of their recommendations to the stirrup splint, but either one in your office setting is appropriate.
And I think, I don't want to speak for them, but I know that one of the issues with the posterior short leg splint is that some kids are going to be tempted to walk on the splint, even though you tell them not to. And so now they have the weight of their body really rubbing the skin between with the splint. So you can get more ulcerations and skin breakdown where there's less contact with skin with the stirrup splint. However, James, you mentioned during the video that really you see less of that because as long as you do a good job with the padding.
Yes.
But we still want to really stress to folks, these are not for weight bearing.
Yeah, that's part of the homegoing instructions about non-weight bearing.
Yeah, but less risk for the ulcerations with the stirrup splint compared to the short leg posterior splint in kids who are not following the directions. But we do want to stress, don't bear weight in these splints for sure. And then so we mentioned distal tibia and fibula fractures. What about fractures of the proximal metatarsals or the tarsal bones? Would there be a reason to use these sorts of splints with those, Dr. Leader?
Well, for the tarsal bones, I think the short leg posterior splint is definitely indicated because that implies a tremendous amount of force to break the tarsal bones, and probably the Reese shoe alone is not sufficient. So for tarsal fractures, for sure, we would use a short leg posterior splint. In addition, we will use a short leg posterior splint for fractures of the proximal fifth metatarsal where there's a concern for a Jones fracture, which is a particular fracture pattern seen in adolescents most of the time, where the bone just does not come together very well, and there's a risk of some necrosis based on the arterial supply to the bone. These fractures oftentimes require pinning in the operating room. So initially we make these patients that we're concerned for this type of fracture pattern, we make them non-weight bearing, and we place them in the short leg posterior splint versus a cast shoe initially. We do use the cast shoe or Reese shoe primarily for other injuries of the foot that do not involve the tarsal bones and are not Jones fractures of the fifth metatarsal. So for those fractures, we'll use a Reese shoe.
So again, proximal fracture of the fifth metatarsal. And this is just a pearl that all pediatricians should have. Just like if you have snuff box tenderness, we talked about in our last episode in the wrist, we're worried about a scaphoid or navicular fracture.
Yes.
Those are ones you don't want to miss. A Jones fracture is kind of the equivalent in the lower extremity, and that involves a fracture of the proximal aspect of the fifth metatarsal.
Yes, and oftentimes, if you were to look at the x-rays yourselves, oftentimes there's an apophysis there, a growth plate, that you can confuse with a fracture. So one little trick is that the fracture that is consistent with a Jones fracture usually runs horizontally to the bone versus vertically in line with the apophysis. That may clue you in. If there's a vertical fracture, it's probably not a Jones fracture. But if it runs horizontally across the bone and into the joint, particularly if you see the fracture go into the joint, then that's the type where you really need to be concerned of the Jones fracture.
Yeah, absolutely. In terms of, you talked about a cast shoe or a Reese shoe. James, what are those? And we do have depiction in the videos for folks, but what do we need to know about Reese or cast shoes?
Well, basically, they're a hard sole shoe that prevents, when the patient is ambulating, prevents the patient from being able to move their foot. It relaxes the muscles, the bones in the foot. So basically, they're immobilized.
Yeah, and
with ambulation,
and it really just, and I in the video you pointed out that it really prevents there being movement at the junction of the metatarsals
Yes.
to the toes.
Yes.
And so since those can't bend, that can offer quite a bit of comfort to folks who have a fracture in a metatarsal or in a toe.
Right. Absolutely.
Yeah. And then those, in terms of sizing, you also mentioned in the video that you really want these to be longer than you would a typical shoe.
Right. People tend to think it should fit snug, but what it should do, once placed on the patient's foot, they need to stand for you. For what happens is it gives you a true size of where their great toe will land. And you should have a good inch, a quarter inch to an inch of room off of the great toe once they're standing.
Yeah. And that also just has some extra material then to sort of prevent or to protect them from bumping into things.
Absolutely.
But since it's longer than a regular shoe is going to be, they also need to be extra careful when walking because you could trip over the edge.
Yes, absolutely.
Yeah. It kind of makes those dynamics a little different.
Right.
Yeah. And then we also talk in the videos about Aircasts. So what are Aircasts? First, I'll ask you that, James, and then Marc, when you use these.
The device itself is just used basically for ankle sprain strains. They prevent basically lateral medial movement of the ankle to help support it and immobilize it.
Yeah, so this is not a cast, really. It's has some air in it, but it's and again, folks can watch the video and see exactly what this looks like.
Exactly.
But this is not really going to be for fractures. It's more strains and sprains, or when we suspect an occult fracture because there's tenderness over a growth plate of the distal tibia or fibula, but the X-rays are normal, so we don't. Could there be a Salter-Harris 1 injury at the growth plate location, but we don't know for sure. Aircast would be appropriate in that situation, Marc?
Yes, that's one of the indications that we will use it for. I tend to use it more for those patients who are not very swollen in the ankle joint. So if you have a patient who has an ankle injury who has open growth plates and they are very swollen and the x-rays are read as normal, you're still probably pretty suspicious of a Salter-Harris 1 if there's a lot of swelling at the lateral malleolus and tenderness to palpation there. So those I may put into a short leg posterior splint or a stirrup versus the Aircast. I look at the Aircast more for, the kind of, let's say, 8-year-old who was running and twisted their ankle and fell, and they come in and they have some ankle pain, but there's no swelling, there's no bruising. The exam is pretty normal other than some tenderness at the site. And then their films are done and read as normal. I may choose to use an Aircast for them. I think the important point is that any child with an open growth plate needs to leave immobilized initially from the office if they have an ankle injury and tenderness over either malleolus, and how you choose to immobilize them may be open to discussion.
Yeah. So the stronger you feel that a type 1 injury could be there with a negative x-ray based upon the symptoms and how much swelling and tenderness and maybe to a degree the mechanism of injury, the more likely that you would use a fiberglass splint rather than an Aircast.
Right. And remember not to discharge them with a diagnosis of a sprain or strain when they're still growing and they have open growth plates. That I usually will write the diagnosis as ankle pain, ankle injury.
Yeah, so that's going to be a really important distinction, because if you call it a strain or a sprain, then there's going to be this assumption that there's not necessarily a growth plate injury there. But it's going to be important for these kids with open growth plates to follow up with somebody in 7 to 10 days to make sure that that pain is better, on its way out rather than getting worse. And then if it's not getting better or it's getting worse, then you would want to get repeat films, because a few days later, as the growth plate injury starts to heal, you will see some bone change, correct?
Correct. So typically we'll refer them to the orthopedist or sports medicine physician for referral 7 days after the injury. And then if they're still tender, they'll get x-rayed again looking for that callus formation that you pointed out.
Yeah. And if it's a minor injury where they have the tenderness, but not a lot of swelling, so we have a lower suspicion for a Salter Harris 1 fracture, following up with their regular doctor may be fine too. But knowing that if that pain is persisting, you need to recheck x-rays or refer them on.
Yeah. I think if you re-examine them in your office 1 week later and they're pain-free and running around the office, you take the Aircast off and you don't need to re-x-ray them.
Yeah. Totally makes sense. So let's march up the leg a little bit and talk about Shauns Wraps and Immobilizers. James, what is a Shauns Wrap? And then Marc, when would we use those?
To start off with Shauns, it's two particular pieces of material. It's the soft web roll added with the ace wrap. It's generally used basically in the knee area, and we will apply the web roll first, and then we will apply the ace wrap over top of that, layer by half, distally to approximately. So,
and when you say by half, it's the width of the material
Absolutely.
with which you are wrapping it. And then that's a single Shauns. A double Shauns would be the cotton roll, then an ace wrap,
Yes.
and then more cotton roll, and then an ace wrap.
Yes.
So it's just a bulky dressing
Yes.
that provides support, but not complete immobilization.
exactly.
Yeah. And Marc, when would something like that be useful?
I think we use that mostly, as James pointed out, around the knee, and we'll use it when we're suspicious for ligamentous or cartilaginous injuries in the knee. So you're thinking of, let's say, a football player who has their foot planted, takes a hit on the side of the knee, comes in with a large effusion, swelling around the knee joint, negative x-rays maybe other than a fusion and the notation of some swelling. Those patients, are very suspicious for ACL injuries or other ligamentous injuries. Those patients we will put on the double Shauns wrap and then have them non-weight bearing with crutches.
Yeah. And then compare that to a knee immobilizer, James.
Okay. Knee immobilizer is a lot more rigid. We carry 3 different sizes at our institution. We have a 12-inch, a 19-inch, and a 22-inch. Basically, it's all Velcro with 3 metal rods placed into the apparatus. Once strapped onto the knee is totally extended, and they cannot bend it at all. It's totally immobilized.
And we have a video of how you size those and
Yes.
apply them that folks can watch. When would you use a knee immobilizer, Marc, rather than a Shauns wrap?
We use those primarily for the following indications. One is a dislocated patella that you have reduced, or where you have a patient who gives you the history where you suspect that they had a dislocated patella and they have spontaneously reduced before you see them. So again, you get this patient who falls to the ground. They report that their patellar kneecap was noticed laterally. 90% of the time it's laterally. And then even if they say, it was definitely visibly in the wrong place, and then I stood up and it popped back in, those patients still need to be immobilized because the ligaments are very lax at that time. So either by history or a clinical diagnosis of a patella dislocation, they need a knee immobilizer. We also use it for tibial plateau fractures and fractures of the tibial spine.
Yeah. Or a fracture of the patella.
Or a fracture of the patella, yes.
You may use a knee immobilizer. So since your leg is straight, extended, and can't move, this would make using crutches a little bit difficult. James, how do you get around that?
Yes. With the affected leg, when they have their knee immobilizer, they tend to circumduct their leg out when they walk. So you cannot have a crutch on that same side because the leg would actually hit your crutch. So we recommend one crutch with a patient who's using a knee immobilizer.
To sort of help them get around.
Yes.
And obviously if it's an injury that is non-weight bearing, you would not use a knee immobilizer.
Right.
For that. So let's, as we consider all of these splints and devices, James, what are important homegoing instructions, I guess, especially for splints, where you're using that fiberglass material? What are the key things that you tell patients to watch for?
The biggest one, speaking lower extremity, please do not walk on it. Do not get it wet. Do not remove it until seen by provider.
Yeah, good.
Those are the big threes.
Yeah. So keep it dry.
Yes.
That's going to be important. So how, parents will ask, well, how do I bathe my child, or how do I keep clean with this?
If you have an older child with a lower extremity splint, we just have them use any plastic bag, but hang their leg off the side of the tub so it's not submerged in water. Wash up, get away. If they're small or toddler, preschooler age, we just recommend wash ups. That's it.
Yeah.
Yep.
Until they're seen, and it's either replaced with a waterproof cast or they're not using it anymore. Yep. And then tell us about circulation checks. So why is that important, and what should families do?
Typically, we want them to check for circulation several times throughout the day, just to make sure that that extremity is responding well to treatment. And if they are taught a cap refill, and that cap refill has a deficit, they are to immediately return and be seen by a provider.
Yeah. So really just checking circulation distal to the splint.
Absolutely. And
making sure that they get in to see someone, or unless you've taught them how to put it on and they can loosen it themselves.
Right.
Great.
Can I add just one thing, Mike, to that? Sometimes these splints and casts to the lower extremities are on for quite a long time, 3 to 4, 4 to 6 weeks. In those patients, sometimes I'll recommend that they get a cast cover online. And these are the inflatable covers that go over the cast and keep it waterproof. And on the internet, generally, you could find them relatively inexpensive for about $24, and it's well worth the value.
Yeah, and for most of these kids, you'd recommend that when they're bathing or showering.
Sure.
Probably not a good idea to go swimming with a splint on with a new injury.
Correct.
Yeah, absolutely. And then we do have a couple of fantastic helping hands. Those are our patient handouts here at Nationwide Children's Hospital. One on cast and splint care, another one on circulation checks, and we'll put links to those in the show notes. And you're absolutely free to use those, even though you may be a physician that's not affiliated with us. You're welcome to use those in your practice as you apply splints.
Dr. Patrick, also about those helping hands, what people don't realize, they're written at a 5th grade level, so they are very simple to read, and for any patient population to be able to understand.
Yeah, absolutely. Yeah, and again, links to those in the show notes so folks can find them easily. I want to spend some time talking about crutches. We've mentioned them here and there. James, how do you pick out the right size of crutch? At what age would you start using them? And what teaching instructions do you give? We do on the video. We show exactly what we're going to talk about now, so you can get that visual. But what are the key points?
First, I always ask the patient or family about how tall the patient is. I get just a round number for that. And we carry crutches in basically 3 different sizes. We have an adult size that goes up to about 6 foot, 6'2". Then we have a tall adult that goes up to 6'10". Then we have what we call the youth, which is basically about 4'7". 4'7". So I get a ballpark area of how tall the patient is, and then I go grab that crutch. But then you have to physically size that crutch to the patient once you have the crutch. So,
and how do you do that?
There is adjusting buttons that are on the neck of the crutch with the actual feet and inches listed right next to it. So once I get that size, I generally go to that area, put the crutch right next to the patient under their axillary, and I should be able, if I fit it correctly, I should be able to get 2 to 3 fingers between the top of the crutch and their axillary pit.
Okay, so you place your fingers on top of the crutches, and you 2 to 3 fingers, and your other fingers should touch the top of their armpit.
Yes.
Okay, so that's how you make sure, and then you're going to teach them not to put their weight on their axilla, but rather put their weight should be on their hands.
Absolutely. That's handle. The biggest key. Your arms are carrying the weight. And once they're placed, their arms are touching the grips. Their arms should be maybe at a 20-degree bend.
Okay. And I would really encourage folks to watch the videos where we actually show crutch walking and the safest way to do that. And you should be prepared to teach folks. And even if they go somewhere else to get crutches, it's important to bring those crutches back so someone can show the family exactly how to use those. Now, in the past, we have talked about how do you go up and down stairs in crutches. We don't recommend that, right?
At our facility, we don't teach that per se because it does add a safety issue. That is why we won't teach that.
Yeah. Okay. So how do you have an extremity injury? How do you get up and down stairs safely?
If they're light enough, if they're that elementary age and they're 9, 10 years old, they can probably be picked up. But if you have a big teenager, they're going to scoot up on their bottom, they're going to scoot down on their bottom, or they're going to get assistance from someone. If they're using the stairwell guard, they're going to have someone on the other side of them helping them up and down the stairs.
So they use the handrail and then someone physically there. Yes. But what really is dangerous using crutches on stairs. Absolutely. And so the whole, it used to be to use the good leg to go down or the bad leg to go up, or which was first. That gets all very confusing for folks. So it's really just best don't use crutches on stairs. And this is a great time to get an elevator pass if schools have
we do that. Yes.
Have an elevator. We mentioned using crutches in kids. You can start using them when they're about 8 to 10 years old, depending on the maturity and the coordination of the child.
Yes.
Marc, what do you recommend for younger kids less than 8 to 10 years of age who may need some assistance with ambulating, but you don't trust them with crutches?
Usually for those patients, we use a walker, which we have available here, or you could write a prescription for one and get it in a medical store. The walker is probably the safest for children under 10. Between 8 and 10, if they're very coordinated, 8, 9-year-old will use the crutches. I have to say that the decision to use crutches is much more thoughtful than you may think, particularly in the wintertime. In the northern states where we are here in Ohio, I don't want to give someone crutches and first have them fall and slip on the ice. I want to be very diligent that if I make a choice to give them crutches, that patient is using them appropriately, is certainly taught in our setting to use them appropriately. And if I feel that they can't, then I'll, even if they're over 10, suggest the walker or wheelchair.
Yeah. And the knee scooters. So the scooters where you put one knee on it, you see a lot of adults with, recent leg surgeries on those. Probably not a good idea for kids, right?
I think that the other children in the classroom would enjoy it as much as the child who's supposed to use it.
Yeah. I mean, it looks too much like a toy.
It just looks too fun.
Yeah. I absolutely agree. So probably avoid those. All right. Well, I think we've covered everything we need to with splints of the lower extremities and crutches, crutch walking, knee immobilizers, Shauns Wraps, ACE reshoes, and Aircasts. All important things and fantastic tools for the primary care pediatric provider to have on hand to apply. And hopefully you found these last couple of episodes useful and something a little different than what we've been providing here on PediaCast CME. Before we leave, Dr. Leader, tell us about urgent care services at Nationwide Children's Hospital.
We offer a broad range of services over the 7 different sites. We see injuries and patients for medical-related concerns. We have on-site X-ray and lab facilities, so we can do basic labs and have quick turnaround times, and X-ray as well. We see many patients in the neighborhoods and are able to see them locally without the need for them to go into the big city.
Yeah. And we really are not trying to replace folks' primary care provider. And in fact, we would recommend that people, if you have a question, this is something that can wait till morning, or do I go in, call your doctor and see what they want you to do. And we really want to work in partnership with community pediatricians, not compete with them.
Absolutely. And one of the main things we do is always refer back to the primary care doc for follow-up. We also provide our pediatricians with a report on the patient discharge diagnosis the next day.
Fantastic. And we have locations here at the main campus at the hospital in Dublin, Hilliard, Marysville, Westerville, out on East Broad Street, and in Canal, Winchester. And if you download the My Children's app for iOS or Android, all the hours for our locations, directions, maps, and wait times are all within that app. So I would recommend that. And we'll also put links in the show notes for emergency services and urgent care services here at Nationwide Children's Hospital. Well, Dr. Marc Leader and James Robinson, thanks so much once again for joining us today.
You're welcome.
Thank you.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to our guests, Dr. Marc Leader with Emergency Medicine and Director of Urgent Care Services here at Nationwide Children's Hospital, and James Robinson, Suture and Ortho Technician Extraordinaire, also with Nationwide Children's. If you haven't listened to last month's episode, we did cover splints of the upper extremity. That was PediaCast CME episode 46. So do be on the lookout for that. You can find it in all of the places where we are found. So Apple Podcasts, iTunes, Google Play, Google Podcasts, iHeartRadio, Spotify, SoundCloud, and most mobile podcast apps for iOS and Android. You'll find the show notes at pediacastcme.org. That's also where you'll find all the CME information to claim free Category 1 CME. And to take the post-test, you will need to register for a free PediaCast CME account. Log into that account. And once you do that, on the show notes page, a post-test will appear at the bottom. And you simply take that, and we'll send you a certificate by email so you can claim up to 2 hours of CME credit for this particular activity, as long as you listen to the podcasts and watch all of the videos that went along with this audio podcast. Links to those are in the show notes for this episode 47 at pediacastcme.org. All of this on the lower extremity. If you want to see upper extremity splints, again, we covered that on PediaCast CME number 46, which you can find wherever it is that you're listening to this podcast. Should be right there, right in front of this one. Don't forget, reviews are always helpful wherever you listen. If you're getting some value out of PediaCast CME, if you're claiming credit, it's free. And so we would just ask in return that you just take a couple minutes out of your day to write a review of our podcast. Wherever it is that you get your podcasts and listen, reviews are always helpful, as those who come after you are trying to determine, hey, is this something that is worth spending my time on? So those reviews, very helpful. Also, please do connect with us on social media. We are on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast CME. We also love it when you tell others about the program, especially your colleagues, partners, clinic and hospital staff, especially those who participate in pediatric patient care, and of course, medical learners, residents, medical students, nursing students. And let your patients and your families know we have a show for them as well, plain PediaCast without the CME. It is an evidence-based podcast for moms and dads, although lots of pediatricians and other providers also tune in as we cover pediatric news, answer listener questions, we interview pediatric and parenting experts, and the shows are available at the landing site for that program, PediaCast.org. Without the CME, just plain PediaCast. That show is also in Apple Podcasts, iTunes, Google Play, iHeartRadio, Spotify, and most mobile podcast apps. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.